Here is a number I want you to sit with before we go any further. A 65-year-old retiring today can expect to spend up to $172,500 on healthcare costs over the course of their retirement. That is a Fidelity estimate, updated in 2025, and it includes premiums, deductibles, co-pays, and out-of-pocket costs across what could be a 20 to 30-year retirement. $172,000. Not on travel, not on housing, on healthcare alone. And when that is the number sitting over your retirement, every single Medicare decision you make carries real financial weight. The 6 mistakes I am going to walk you through today are being made right now by retirees across this country, and each one is quietly adding to that healthcare bill in ways that are 100% preventable. My name is Finn, and this is Finn Retires, the channel that exists to protect your retirement income from the mistakes nobody warns you about in advance. If this is your first time here, hit that subscribe button right now. We put out a new video every week covering the financial rules and decisions that matter most for retirees. And today's topic is one that touches every single person who is enrolled in Medicare or approaching the age where Medicare becomes their primary healthcare coverage. Subscribe, get a notepad ready, and let us go through all 6 of these together. Before we get into the mistakes, I want to make something clear about what this video is and is not. This is not a recap of the enrollment penalty we covered in detail in the previous video on this channel. If you missed that one, it is linked at the end, and I would strongly recommend watching it separately because the penalty alone is one of the most financially damaging things that can happen to a retiree's healthcare budget. What we are covering today are 6 different mistakes, things that happen after enrollment, during open enrollment, or as a result of assumptions retirees carry into the Medicare system that simply are not accurate. Every one of these is fixable. Every one of them costs money when left unaddressed, and every one of them is something you can act on this week. The first mistake is one that a surprising number of retirees make, not out of carelessness, but out of a very understandable assumption. It is the assumption that Medicare enrollment is automatic. Many retirees believe that the government knows when they turn 65 and will simply start their Medicare coverage without them doing anything. And here is the thing. That assumption is partially correct, which is exactly why it is so dangerous. If you are already receiving Social Security retirement benefits when you turn 65, you will generally be automatically enrolled in Medicare Parts A and B, and you will receive your Medicare card in the mail approximately 3 months before your 65th birthday. But if you have not yet claimed Social Security, and a significant number of retirees delay Social Security specifically to maximize their benefit, as we have covered in earlier videos on this channel, automatic enrollment does not happen. You are responsible for signing up on your own. The Social Security Administration does not automatically connect your Medicare eligibility to your decision to delay Social Security. They are separate systems, and enrollment in one does not trigger enrollment in the other. The retirees who get hurt by this are precisely the ones who are making smart decisions about Social Security timing, delaying to maximize benefits, while unknowingly letting their Medicare enrollment window close. If you are not yet on Social Security and you are approaching 65, you need to actively sign up for Medicare through the Social Security Administration's website or by calling directly. Do not assume it will happen automatically. The second mistake is one that a recent survey found affects nearly 4 in 10 Medicare Advantage enrollees. The mistake is treating a Medicare Advantage plan like a static, permanent coverage decision, renewing the same plan year after year without ever comparing alternatives. An eHealth survey found that 39% of Medicare Advantage beneficiaries incorrectly believe these plans are generally all the same from one plan to the next. They are not. Premiums, provider networks, drug formularies, covered services, prior authorization requirements, and out-of-pocket maximums can all change significantly from one plan to another, and they can change within the same plan from one year to the next. The plan you enrolled in 3 years ago because it covered your doctors and your prescriptions at a reasonable cost may look completely different today. Networks shift. Drugs get dropped from formularies. Premiums increase. And because Medicare Advantage plans are offered by private insurers who renegotiate their terms with the Centers for Medicare and Medicaid Services annually, the plan you renew for 2026 is genuinely a different product than the one you bought in 2022, even if the name on the card looks identical. A Medicare specialist at Beckett Financial Group reported in late 2025 that by helping one client switch their Part D plan during open enrollment, they saved that client over $1,100 on medications in 2026, simply by comparing plans rather than auto-renewing. The solution here is straightforward. During Medicare open enrollment, which runs from October 15th through December 7th every year, take 30 minutes and compare your current plan against available alternatives using Medicare's Plan Finder tool at medicare.gov. Input your specific medications, your zip code, and your preferred pharmacies. Let the tool show you what each plan would actually cost you. That 30 minutes could save you hundreds of dollars every single year. The third mistake is specifically relevant in 2026, and it is one that is affecting millions of retirees right now who may not even know it yet. This is the mistake of staying enrolled in a Medicare Advantage plan that has fundamentally changed, or that has been discontinued entirely, without fully understanding the implications of being forced to switch. Medicare Advantage now covers more than 51% of the total Medicare market, with approximately 35.5 million subscribers. But in 2026, 10% of Medicare Advantage enrollees are facing forced disenrollment because their plans are exiting certain markets, reducing their coverage areas, or being discontinued altogether. For those retirees, the path back to original Medicare comes with a risk that most of them never anticipated when they first enrolled in Medicare Advantage. If you leave Medicare Advantage and want to pick up a Medigap supplemental policy to cover the gaps in original Medicare, things like deductibles, copays, and coinsurance, you may find that you cannot get that Medigap coverage at any price, or that you can only get it at a significantly elevated premium. In 46 states, Medigap insurers have the right to deny coverage or charge higher premiums based on pre-existing health conditions if you are not in a guaranteed issue enrollment window. When you first enrolled in Medicare at 65, you had guaranteed issue rights to any Medigap plan available in your area. But if you switched to Medicare Advantage after that initial window closed, and you are now trying to switch back to original Medicare and pick up a Medigap plan years later, in most states, insurers can and do deny you based on your health history. This is one of the most significant and least discussed consequences of Medicare Advantage enrollment, and it is a risk every retiree should fully understand before choosing Medicare Advantage over original Medicare and a Medigap plan. The fourth mistake is one that sounds almost too simple to be a real problem, but the financial data says otherwise. It is the mistake of not understanding what Medicare does not cover, and therefore not planning for those costs. Medicare is comprehensive in many ways, but it has well-known and significant coverage gaps that catch retirees off guard every year. Medicare does not cover routine dental care, dental procedures, or dentures. It does not cover routine vision exams or eyeglasses. It does not cover hearing aids, which can cost between $1,000 and $7,000 per pair and are not one-time purchases. Hearing aids typically need to be replaced every 3 to 5 years. And Medicare does not cover long-term care, not home health aid services beyond a very limited set of conditions, not assisted living, and not nursing home stays beyond 100 days under very specific circumstances. According to Fidelity's 2025 healthcare cost estimate, the gap between what Medicare covers and what retirees actually spend on healthcare over their retirement is a primary driver of that $172,000 lifetime figure. Retirees who plan their retirement income assuming Medicare will handle all healthcare costs are setting themselves up for exactly the kind of unexpected large withdrawals from retirement accounts that disrupt the most carefully designed retirement withdrawal strategies. The action step here is simple. Build a specific budget category for the costs Medicare will not cover: dental, vision, hearing, and long-term care. Consider dental discount plans or dental insurance. Look into whether your Medicare Advantage plan includes any vision or hearing benefit, understanding that these benefits are often limited. And if long-term care is a concern, look into long-term care insurance options before health conditions make that coverage unavailable or unaffordable. The fifth mistake is a relatively recent development that affects high-income retirees more directly, and many of them have no idea it applies to them. This is the mistake of not planning for IRMAA, the Income-Related Monthly Adjustment Amount. IRMA is a surcharge added to Medicare Part B and Part D premiums for beneficiaries whose income exceeds certain thresholds. In 2026, the standard Medicare Part B premium is $202.90 per month. But for a single retiree with a modified adjusted gross income above $106,000, that Part B premium increases based on an IRMA bracket, rising in steps up to a maximum surcharge for the highest income levels. The critical thing most retirees do not know about IRMA is that it is calculated using your income from 2 years prior. So if you had a high income year 2 years ago, perhaps from a large IRA distribution, from selling a property, or from a one-time business event, that income determines what you pay for Medicare this year, even if your current income is much lower. This 2-year look-back surprises retirees regularly, and it means that Medicare premium planning has to account for income decisions made years in advance, not just current year income. If you believe you are paying IRMAA surcharges based on income that has since significantly dropped due to retirement, a one-time event, or other life changes, you can file a form with Social Security to request a review using more recent income data. The form is called SSA 44, and it is specifically designed for retirees whose income has changed since the year being used for the IRMAA calculation. The sixth mistake is one that affects a specific group of retirees, but affects them in a deeply damaging way when it happens. This is the mistake of not reviewing Medicare Part D drug coverage annually, particularly in years when your prescription medications change, when you switch from one Part D plan to another, or when a plan changes its formulary without you noticing. Medicare Part D prescription drug coverage is offered through private insurers, and those insurers change their formularies, the list of drugs they cover and the tiers at which they are covered, every single year. A medication your plan covered at a low copay in 2025 may be on a higher cost-sharing tier in 2026, or it may have been dropped from the formulary entirely. If you are taking medications for chronic conditions and you have not reviewed your Part D plan for the current year, there is a real chance you are paying more than you need to for drugs that a different plan would cover at a lower cost. In 2026, Medicare has negotiated prices for 10 high-cost medications under the Inflation Reduction Act, the first time in Medicare's history that the program has directly negotiated drug prices, which means the pricing landscape for some commonly used medications has shifted significantly. Reviewing your Part D plan during open enrollment using Medicare's Plan Finder tool, specifically inputting your current medications, is the only way to know whether your current plan is still the most cost-effective option for your specific drug needs. Now let me bring all 6 of these together in a way that shows why they compound. Think about a retired couple named Thomas and Helen, both 68, both on Medicare in Ohio. Thomas assumed his enrollment was automatic because he was getting Social Security. He was right, and that went fine. Helen delayed Social Security, forgot to manually enroll in Medicare, and quietly accumulated a Part B penalty before someone caught the error. Thomas stuck with the same Medicare Advantage plan for 4 consecutive years without comparing alternatives. His network dropped his cardiologist's practice in year 3, and he did not discover this until he had a cardiac event and received a surprise out-of-network bill. Helen picked up a Medigap plan when she finally enrolled in Medicare, which gave her comprehensive coverage and the freedom to see any doctor in the country. But she has been quietly paying IRMAA surcharges based on the year she took a large IRA distribution, which she never thought to appeal. Neither of them has a budget line for dental care. Thomas needs significant dental work that will cost between $4,000 and $6,000 and comes entirely out of pocket. And both of them auto-renewed their Part D plans in October without checking whether their medications were still covered at the same tier. They were not. Thomas's blood pressure medication moved to a higher cost-sharing tier in 2026, adding roughly $40 per month to what he pays out of pocket. Thomas and Helen are not careless people. They are educated, well-intentioned retirees who simply were not warned about these 6 specific things, and the cumulative financial impact of those 6 gaps is real and ongoing. Here is what I want you to walk away from this video ready to do. Start by confirming how you were enrolled in Medicare and whether you enrolled on time with no gaps. If there is any doubt, call Medicare at 1-800-MEDICARE and ask directly whether any penalty is currently applied to your Part B premium. Then, during the next Medicare open enrollment period, October 15th through December 7th, make a commitment to spend 30 minutes on Medicare.gov, Plan Finder tool, comparing your current plan to alternatives, inputting your specific medications and preferred pharmacies. If you are on Medicare Advantage, look carefully at your plan's annual Notice of Change document, which your insurer is required to send you before open enrollment begins each year, and check specifically whether your primary doctors and any specialists you see regularly are still in your plan's network for the coming year. If you have high income years in your recent tax history, check whether IRMAA applies to your current premiums and whether a reduction request using Form SSA 44 might be appropriate for your situation. Build a specific budget for the costs Medicare does not cover: dental, vision, hearing, and long-term care. And review your Part D formulary for every medication you are currently taking to confirm your drugs are still covered at the cost tier you are expecting. If this video helped you see your Medicare coverage in a new way, or if it surfaced something you were not aware of before today, please share it with someone in your life who is enrolled in Medicare or approaching 65. The 6 mistakes we covered today are all preventable, but only for retirees who have the information in time to act on it. A share from you costs nothing and could save someone in your life real money on their healthcare costs every single month. Drop a comment below and tell me, which of these 6 mistakes surprised you the most? Were you aware that Medicare Advantage plans change this significantly from year to year? Had you heard of IRMAA before this video? Tell me what you did not know, because your answer genuinely helps me understand what to cover next for this community. I read every single comment on this channel, and your response matters here. The next video on this channel is going into a comparison that millions of retirees are getting wrong right now, specifically the real differences between Original Medicare and Medicare Advantage that insurance companies are not volunteering to explain before you sign up. It is a follow-up to what we covered today, and if you are trying to decide between the two, or if you are already on one and wondering whether you made the right choice, you do not want to miss it. Subscribe now so it comes to you automatically. Take care of yourself, protect your healthcare budget, and I will see you in the next one.